to Colonel Wilson to begin.
Okay, thank you, Sarah. Good afternoon, everybody. This is Lieutenant Colonel Rich Wilson, the director here down at PASMA. In the room with me is Brian Millard and Jenny English, or Jenny Butler English. We haven't decided which, but they are two of our analysts here at PASMA who do a lot of work with various aspects of the BMI data that's available. And then there's a few other PASMA members in the room as well. If you need to find us later, here's our contact information, a little bit about PASMA. We do fall under the PAE directorate out of OTSC Metcom, but we are lock, stock, and barrel located down here in Fort Sandy. A quick purpose and outline is, we just want to do a general information brief on body mass index data, its sources, processes within the Metcom. We spent a lot of time looking at statistics and do some stage setting and metrics that are out there. At the end, we'll probably toggle out of the PowerPoint presentation and jump into a couple of live tools that are out there that are available for the Metcom and utilization of managing this population. So by way of outline, we'll do some stage setting on the PhD's vision. We'll get some of the broader data on the nation as a whole. We'll try to talk specifically about our BMI data here in the DoD. Not only how it's collected, but what the sources are, and some of the coding implications as well. Towards the end, we have a lot of Jenny Butler's work has been on really expanding on this data, looking at cost utilization of the different BMI categories and groups, looking at comorbidities and overall cost analysis. And as I mentioned earlier, at the end, we'll wrap up with using the BMI tool and some of the applications we've built down here to get access to that data, to include the P-man aspects of BMI and the BMI metrics. Okay, let's start at the top. As many of you have heard, the TSC has a very distinct vision of transforming the way we deliver healthcare, moving from a system, moving towards a system for health. And one of the core tenets of that is this performance triad of sleep, activity, nutrition. Not only help drive the way the active force works and its readiness aspects, but also our dependent family members and retirees. And overall, the key piece being the need to balance these three things in order to build and sustain overall health. This is in concert with a number of other Army initiatives on the whole. As many of you have heard about the resiliency campaign, comprehensive soldier fitness program, and then there's the DoD's Operation Live Well and IR Life, that are a number of different pieces that are out there that this kind of ties into. So the more and more cases we're starting to see this in both our behavioral health work and in some of the obesity work, is that the Army as a whole is embracing Metcom products and/or initiatives in order to ensure that we have a ready and resilient force. Some of our key pieces, obviously, is some on the education and training side. We've got validating tools and that are being distributed to the field. The VA, DoD, PPGs are a core and critical piece to that. Our health associate folks have a marketing and studies really are a kind of a marketing tool at the same time that really need to be validated and communicated in the right way in order to have it achieve, in order to get the achieved effect. And then again, on the other side, any of you can put diet or into Google and get 1,000 different ways and suggestions on how to cut weight, from these fast diets to calorie counting to different programs that are out there. But the Army Metcom has got a mission here, or a certain general's got a mission here, is to provide the right information to our command in order to help, again, achieve our desired effect of having a fit and ready force. Continuing on with the THE vision, I think the biggest thing that we can have an impact on, and she's spoken about this at length, about the time that happens outside of our ability to have contact with patients. at any given time, we see, we only see about 85% of our patients in any given year to start with, and what we do is as low as one appointment, 15-minute appointment to some patients that come to see us more often, but it's a very small amount of time in their overall lives in order to help change their physical and health behaviors out there. So we need to be able to provide our leaders and provide our staff tools and things they need in order to develop. We always kind of make sure we reference some of the official pieces that come out here. She reiterated the BMI guidance on Chief's memo about adult and child obesity. Key pieces to pull out of here, and Brian's going to cover some of this here. You need to measure objectively, not subjectively, but objectively, BMI data, outpacing. We need to use the VAU and ECBG guidelines and when it's appropriate. And this is all in concert.
Excuse me, Colonel Wilson. I think some of our audio-only participants haven't muted their phones. Please mute so that we can concentrate on the presenter.
Okay, thank you, sir. So, as I mentioned earlier, the BMI effort, this is a broad national effort, which we'll look at here in a second, but the Army's got a broader effort to really embrace the benefits of having a fit force. This performance triad is a key piece to that, and make sure we have the right levels of activity, the right information and levels of nutrition, and as well as the right components to a healthy sleep diet. The performance triad is the big initiative surrounding that. There's a pilot study going on, being pushed out right now, coming out in 3 sites at Joint Base Lewis McChord, Fort Hood, and Fort Bragg. So about a battalion each of soldiers. So it's a fair number. We'll have a very nice sample of soldiers that are gone through this program. It's north of 2,000. But again, we can't just go out and do the classic, every soldier in the room, we do a briefing, we walk away. The intent here is to provide a number of different tools and applications that they can use. This is being built out of comprehensive soldier fitness. There's a number of online applications that go out with them. In the graph here, you see some of those displays. It's very it's very personalized, looking at your weight, your activities, diaries, logs are there to help people track not only the calories they're taking in, but how much sleep they've gotten, what other activities they have going on in their lives. I think also here on the screen you see some of the Fitbits, which are help. There's a number of different products out there. Nike runs their iFit products, and there's a number of different pieces that you can strap on or strap into things to track, walking or running or different machines that you do cardiovascular fitness on. So some of those tools will be distributed and deployed to these troops as part of the study. Okay, let's take a look at the national obesity issue. As we all talked about many times before, the Army or the DoD as a whole is really a reflection of the broader nation. So we definitely are not immune to some of the same things that they express. The key difference being we're definitely a younger population on the aggregate, and we have less, therefore we have less expression of some of these chronic diseases that we'll see here in a few minutes. But at the same time, we're less influenced by some of the regional external influence that you'll see out on maybe some of the mass CDC produces, for example, that looks at obesity rates by state. As our population is fairly transient and is less influenced by, say, regional culture or regional cooking or food sources. But I think we all recognize, and this is again, just a sort of a place setter here, that, we have a massive obesity problem. If you look at the trend chart on the right, the number of folks who are either obese or overweight, starting in 1960, has dramatically risen over the last 40 years. In particular, what's always interesting to me is that the people in the overweight population, while increasing, have been relatively small slope, but the number of patients who are in the obese category has really had a marked increase over those number of years. So it's more than double in adults. And an even scarier proposition is the number of children who are fall in this category has tripled. We have a couple recent studies. At the end of this slide deck, you can see all the different references that we have for different papers or different points in the presentation brief. A recent study predicts that 42% of Americans will be obese by 2030. That doesn't mean overweight. That means obese, and 11% of that will be severely obese. There are differences in the population. In the Mid-Com, we don't see it as much, but in the nation as a whole, you definitely see differences in racial and ethnic minorities, lower education and income level groups, and then rural areas have a significant issue as well. The guys in the room were really proud of themselves when they found the donut bacon cheeseburger over there on the right side of the screen. My photo of the escalator going up to the fitness center is my favorite. But there's a number of different things that we have going on in America that really influence why we've seen such a market change. Some point to the sedentary lifestyle of the technology has created for us, whether it's televisions and smartphones or most of us work behind desks. But there's some broader issues and largely economic issues that are really at heart here. We've definitely developed or built this cheap food model in the United States. For many people, it's cheaper to eat out at Taco Bell than it is to make a meal. Many people simply don't have access to that, which we see not only in the rural areas, but also in urban centers. We've got a lack of really good and robust, comprehensive health food choices. Portions, I think we've all been to McDonald's or wherever, and they auto supersize everything. Everything's gotten bigger and bigger and bigger. There are other issues at heart here as well. We've got family history, genes certainly play a role here. There are health conditions. Hello? Okay. Other health conditions, lack of sleep. Weight definitely goes up with age. I was commenting in here about how hard it is, I think, as I've gotten older to keep weight down. And then overall, we've just got an imbalance with our lifestyle, from an active lifestyle to a relatively inactive lifestyle for many people. And there's plenty of studies too that suggest that even though you may work out one time a day, that does provide some cardiovascular fitness. May not have an effect on your overall intake if the other areas are out of whack. So I'm heavy, so what? Well, the issue really is development of these chronic conditions. I don't have to list all of them. We threw the big guys up here: diabetes, hypertension, heart disease, stroke, even certain types of cancers. The key piece is that when you increase the BMI, your probability or your likelihood of developing one or more of these chronic conditions also increases. Some really interesting numbers here. Persons with a BMI of 35 or more are 20 times more likely to develop diabetes. Obese men are more likely to have a stroke. And then from that, we take these chronic diseases sort of one step farther. It's not too far to get to the leading cause of death and disability is chronic disease, and accounts for 7 out of 10 deaths in the United States. And then a really staggering one on diabetes, but it's pretty commonly known, I think, for most people in the healthcare facility anyways. The type 2 diabetes is the strongest correlation with obesity. And then is the leading cause of early death in the United States as well. Some more bad numbers here. The leading cause of disability accounts for 7 out of 10, which we talked about. Yeah, this is the same slide. I guess we wanted to show you the chart data on the right, and that's the number of patients that have, the number of Americans in the millions that have one of these chronic diseases. Just in the last 15 years, this chart here shows the last 15 years, has gone up dramatically. And the big ones being diabetes, heart disease, stuff like asthma. We didn't talk about mental health diagnoses earlier, but it definitely has an issue with BMI and tipping point. So, one aspect of it is kind of just the overall health of people, but for us, we unfortunately have to not only deal with treating them, but paying for it. Obesity now accounts for almost 21% of healthcare costs, $190 billion annually, and growing. There's a 27% inflation on these expenditures from 87 to 90 for 2001. As you might imagine, with those chronic diseases, these obese patients have 48% more inpatient days and are more likely to come in and more pharmacy utilization. Chronic diseases account for 3 out of every $4. That's a fantastic statistic. Most of this stuff is preventable. When we looked at TRICARE costs, they nearly doubled from 2001 to 2005. $18 billion to $37 billion in 2005. And then some of the other big pieces some of the other big pieces that are really sort of interesting is our ability to do our job. And that doesn't just mean soldiers. That means people in our healthcare facilities. That means our firemen, our emergency personnel, people who are overall contributing to national security in many different ways, but also in many different aspects of our lives. So we have increased absenteeism, which has a distinct and very real cost. The number of recruits that we've turned away, or the number of soldiers that put out of the Army over the years has been pretty large, and the cost of recruiting and training an individual soldier is pretty expensive. Brian's got $60 million annually here. Now, I will say this: the chapters for overweight kind of went away in the height of the Iraq War, right? We saw that in a lot of different data studies. And now that we're into a downsizing Army, exercising the peace dividend, we are definitely seeing a rise in the number of soldiers who are being chaptered out for disability. And this one there. Okay. Who's Carlin's out? I'm asking the guys that are really starting.
You published something, we thought it was...
Oh, fantastic. Too fast to fight, too heavy to join, simply ineligible to serve.
That's where the cost of recruiting and training replacements per person came from.
All right, so that was 16 slides of bad news. I think there really is good news. This is all preventable. It starts with interaction with the patient. It starts on the aggregate with the data that we have available. And with that, I'm going to turn it over to Brian Millard, who's going to walk you through some of the BMI data, basically collections and reporting.
Good morning and afternoon for some that are in different areas. A lot of people have already they really already kind of know what the BMI calculation methods are, but we're just going to go over them briefly for those that don't. What we use the CDC calculations and guidelines and formulas when we calculate the BMI. And it's up on the screen, but I don't necessarily need to go over the formula. And then the BMI adult weight categories, again, they're based on the CDC guidelines and formulas. And really, we look for, and do our reports, some of our statistics in this presentation, we combine the overweight and the obese. To kind of give you an idea, because if you're overweight, we fall under some of the guidelines, same guidelines as obese. I think somebody's still of you. We're getting that over here. We also have a BMI widget on our website, which we'll go to live once we get through the majority of the slides. And it's pretty easy to use. I mean, it's just like the same thing that's on the CDC website, which is where I believe we go for that.
If I can jump in real quick. Sorry, this is Jennifer. I think if you haven't done it, you should calculate it. Because I did this, but I did not. I run this. I run a lot. I do a lot of stuff. I'm pretty famous. But according to the CDC, I'm at 25, right on the nose BMI, 5'11", 80 pounds. And there's something it kind of puts it in perspective because like this kind of in my mind. I think an overweight obese person in the CDC is something different than myself. And then when I calculated it, then I can compare myself to other people that I can see. I think it starts to bring the problem home to you a little bit. I mean, I think some people, it's very clear what they're, but I think the other edge, the people who are on the margin. And the reason that matters is that when you start to look at the broader categories, I think it's put it into perspective. That's how big or small this population should or shouldn't be. Okay, thanks, Brian.
I want to mention the age category breakdowns for the CDC. The adult age category are equal to 240 months, and the child teen calculations are less than that. And even though the BMI is calculated the same way for children and adults, the criteria of it's easier to interpret the meaning different. The child teen is the calculation is determined by a percentile ranking on age and month and gender. So it is different between male and female, and then age. And that's the two reasons that you see on the slide. That's the amount of body fat change age and the amount of body fat between girls and boys.
Brian, there's a question. Is there also a distinction for adult men and women?
There is not. The CDC just views men and women similarly when it comes to the BMI calculations. And then also, I want to mention that there are some kind of weird things out there when we're looking at the military population because we do have a lot of soldiers that fall into that 17 to 20 age group. So when we break them out, they fall into that teen child calculation by percentile rate. So that's something to consider when you're looking at the data. The data sources that we use are the MDR. Unfortunately, it's pretty difficult to get to if you don't have access or you don't have a programming background. So that kind of leaves it up to a pretty slim population of individuals that can extract the data. It is on the way into M2, so it's going to be available at a more local level eventually. Not sure what the time frame is for that, but it is on the way to it. There may be some other people online that can speak to that a little bit clearer than I can. We do go when we pull up the total enrolled population that's equal to or greater than 2 years old, and we use those. We get the height and weight data out of the vitals table, that's what's going to be put into the M2. We also use the CDR patient file, which is, again, it's another one of those components of the CDR that were migrated over into the MDR for our use. We use stats to extract it, and we apply various filters and processes just to kind of whittle it down a little bit and make sure we're getting what we're getting. We add the additional age group that's not available to calculate the child teen BMI calculations. and we make sure that we're grabbing Army, Venus IDs, and then we create a combined beneficiary category to put us more in line with the age groupings that the CDC puts out. There are some definite data quality issues and outliers. We're finding people who are 12,000 pounds who are 3 feet tall. I think that's definitely got to do with the human error on the entry. Adults under 2 feet tall or BMIs over 100. I do, just based on the calculations, that's pretty much, most of those are impossibilities. So, and then the variations in data collection methods, because there is really no standardized process across the AMED or MedCom that speaks to how we're supposed to objectively gather that data. There's different scale calibrations. People are subjectively inputting height and weight. A patient walks into a clinic and they say, how much do you weigh and how tall are you? As opposed to actually heighting and weighting that individual. It used to be that there was a metric and the standard entry. And I believe specifically it is now just a standard entry. At least that's what's portrayed in the data in the CDR vitals table. It comes out as a standard entry. So weight in pounds and height in inches. So make sure when you're doing your entry that you're going with the standard entry when you do it when you enter into the Alta record. Again, I already spoke about the objective height and weight measurements, self-reported height, weight, or unacceptable entries into the Alta record, and that is that's basically mentioned in the Surgeon General's memos on adult and childhood. We do not clean the data for outliers. Data quality issues and entry issues, for the most part, belong to the MTF, because the data we're pulling out of the CDR is the MTF's data. So we don't clean them. We leave them in there so when your people pull those action lists down off of our website, they can see what those outliers are and go back in and correct them.
Brian, can I interrupt for a minute? There's a question in the chat. The question is, if a service member is weighed in their ACUs and boots, should their weight be adjusted before entered into Alta?
That, I believe, is on this slide right here. So, go ahead, sir.
I was just going to say, before we move on, it should be pointed out that where there are errors in how the information has been put into the encounter, use the most recent. Right, Brian?
That's right.
So,
most recent within the last 12 months.
Some of those fingerings, kind of get fixed later, which is it's really not the appropriate method to do that, but it does catch a number of that. And then the data we're going to see later that Jenny English has, she's excluded and cleaned up the data to do her study. We're approaching that more of a research paper than anything else. All the other data you'll see on any of the BMI tools are essentially unlinked.
Correct. So, getting back to the CSG's memo on child adult obesity, I mean, it's out there. If anybody has any questions or needs the memos, I can put them out there. We may be able to include them in this slide deck package. But it says collect and assess BMI at each visit. Now, there's some interpretation there to her memo versus some other information papers that are attached to her memo that speak to every clinic visit versus every outpatient visit versus every primary care visit. So, again, I've requested clarification on that, and we're still kind of waiting to try it because I get a lot of questions on that almost daily. What does this mean? And does this mean we need to go out and purchase scales for every outpatient clinic or every B members that we have in our facility? So, in answer to that question, we're still waiting on clarification. It also speaks to the ADOD clinical practice guidelines, the use of those, and then the standardized procedures for objective collection. And this answers the question that was asked in the chat about what you're supposed to subtract based on what the individual's wearing at the time of height and weight. And it also talks about civilians. So it's not just basically soldier based. So if your civilians come in, you're weighing them and taking their heights, you can subtract 3 pounds per clothes before they're put into the open entry.
Brian, can I ask you a couple more questions from the chat?
Sure.
Where's the appropriate place to enter height and weight? Are you only looking at data entered into the vitals, or are you taking height and weight data that's entered in the AP section?
We're taking the height and weight entered into the vitals section, just the vitals section.
Great. And in the pediatric clinics where they use centimeters and kilograms for height and weight, do they need to convert them?
Yes, they do, because the entry in ALTA is standard. It's not metric.
Thank you.
Documentation and clinical coding. We have Mr. Staley here if any questions arise from this slide, but it should be coded on every clinical encounter when its presence requires education, treatment, and it impacts the medical clinical decision-making process. If it's not due to an underlying disease process, then it needs to be coded utilizing the appropriate ICD-9 CM code, which is in a 278 range. And again, it needs to be captured at every reasonable opportunity. Screening and prevention of adult overweight and obesity, paragraph 2 of the DSG's memo on adult and child obesity. And this is another controversial comment that provider documentation is not required to capture BMI data. Mr. Staley may want to comment on that.
Because BMI is not a diagnosis, we're not making any insinuation about it. But according to the American Hospital Association, CMS, American Health Information Management Association, and the American Hospital Association create the rules for ICD-9 data capture. The presence of BMI alone can be documented by any member of the healthcare staff and does not require documentation by the provider. However, if obesity is determined to be present on that individual, obesity must be documented by a provider. So ICD-9 codes in the range of D85.0 to D85.45. This is just a broad range, and what they represent is different percentiles of BMI. So you can go all the way from, a person who's just barely obese to someone who's extremely morbidly obese is what those codes represent. Just a wide range and variation in BMI capture.
Okay. Before you guys move further, can I ask a couple questions from the chat?
Sure.
And then if Royce is going to answer, ask Royce to move a little closer to the microphone.
Yeah, I tried moving the phone to him, but I was a little late. Sorry.
Is there a fix? If someone enters only height or only weight or enters them separately, there won't be a BMI calculation. Is there a fix for this?
Yeah, they're both the height and the weight.
Right, because you can't calculate a BMI with just a height or a weight.
And then, Brian, you spoke to this.
So this is the question, but yeah, they're both required.
And ALTA actually calculates the BMI for you, so the provider can see what the patient's BMI is. However, that does not translate to the CDR vitals table.
That was Colonel Talbot, and he's writing a response back. Let's see what he has to say. Hang on just a second. We're waiting for Colonel Talbot. Colonel Talbot's saying that if the height and weight are entered a second time or a second apart, it will not calculate.
Yeah, I'd have to look at that. I'd say if the two elements get saved, you know, obviously what Brian was saying before is that the BMI calculation that Alta does is not what gets written to the CDR, MDR. Right. But just the height and weight data values are. But I'd have to take a look at the data entry part here that you're talking about. We can take that up as an issue with the CMIO guys.
Thanks. And one more.
And also, I'd like to kind of answer the question about the height and weight can be entered as metric and standard. I can tell you that the vitals table, the CDR vitals table is specifically in standard as opposed to metric. So it translates in standard, and that's the way we do it. So, you know, that may be something we need to get with Wendy Funk about, or the MDR folks, TMA, to find out maybe, because it used to be in kilograms and centimeters, but they removed that. So it does not translate to the CDR vital table.
Okay, this was kind of real quick. I'm reading Mark Hansen's question. The height and weight, those values are the only thing that do transfer to the vital table. It's that BMI calculation that Alta presents to the user is what does. We take that height and weight and do the calculation on this end. Okay, we don't have any other questions. We're going to move over to Jenny English. She's one of our newer analysts here at PASMA. We swiped her successfully from CAS down the street, where she was doing this very type of work, these much longer term, sort of deeper studies. She started to really explore, as I mentioned before, there's a distinct difference in our population. When you read CDC data, you're looking at primarily Medicare, Medicaid data. So a distinctly different population than ours. A little older, a little more time to express some of these chronic diseases. So we went ahead and pulled our own, even though we have our own retirees, it's certainly true, but we went ahead and pulled our own cohort. And Jenny's been spending the last several weeks really exploring that. So without further ado, I'll turn it over to Jenny.
As Colonel Wilson said, the purpose of this study was really to take a deeper dive from what we already know from Ryan's TMI metric into the obesity problem in the Army. We looked at cost, healthcare utilization, and disease among the Army population. Basically, the foundation of the study was what Brian's already discussed, the cohort from his metric. One of the strengths of the study is that it's based on actual vitals measurements, height and weight, and calculate BMI, whereas previous published studies in the military population were based on a lot of survey reported data, self-report. The CDR vital data became available more recently, so to use on the back end of an analysis in this manner. One thing to keep in mind as we go through this study is that the Army uses BMI clinically, but as far as Army weight standards, there is the Army weight table used, which accounts for height, weight, gender, and age. So we did a quick little study on, the differences as far as screening for overweight and obesity using BMI versus the weight table. And using BMI is a lot more strict, so it captures a lot more overweight and obese people. And the other, one of the nuances using just BMI is that some people with a more muscular nature are classified as overweight, like Colonel Wilson. He is not that man. So just keep that in mind as we go through the slides.
You do have donuts in the room.
Yes, we did eat donuts before this. Okay. The cohort for the study we're calling the weight cohort. It was built on one fiscal month of data, which is basically a snapshot in time. Should be representative of the population. And it started with about 1.4 million people. And after all this meeting was done, it was about 1 million people. We matched data, the enrollment data, to the CDR data, and harnessed the vitals measurements to calculate BMI. Persons less than 2 were excluded because BMI is not a reliable indicator of body fatness in that young of a population. And then a lot of data cleaning was done to clean out all the invalid or impossible height and weight values. The same weight categories the CDC uses were used for the study. And then we matched that weight cohort to the inpatient and outpatient data to get the disease and cost data. And we further excluded pregnant people because they can skew the data a little bit. Then let's go to the next slide. We derived cost using variable helpful cost. In the military and in the civilian world, it's not very straightforward always. But this is what we went with in order to evaluate costs. But probably understanding fully how these cost fields are derived is a separate session in itself. We can do the backup slide real quick. Okay. HRQ has made a new classification system for ICD-9 tests called the Clinical Classification System. And basically it takes 14,000 diagnosis codes and them into somewhere around 300 distinct meaningful categories, and it makes it much easier to present this kind of data. So this is how the analysis is executed using CCS categories. And also, HRQ recently developed a chronic disease indicator tool, which also goes through all the ICD-9 codes categorized chronic or not chronic. So this is how we did the chronic disease portion of the study as well. Oh, that's not. Oh. Okay. So those are definitions. This graph depicts the distribution of BMI within the weight cohort. As you can see, the graph is an overweight category. You can see how many people are overweight in the population by BMI. And again, they're defined by BMI between 25 and 29.9. People who had a BMI over 40 were lumped into a plus BMI there at the end of the chart. You can see that little peak. This table just has some descriptive statistics surrounding height, weight, and BMI. Excuse me. The main points are in the first top, for the adult population 21 and older, the average BMI is 27.9, which is about the midpoint range for the overweight category. BMI for the active duty population was 26.9, which is on the very low end of the overweight category. For children, the average BMI was close in the normal range, which is good. And overall, the last box there, the BMI is 5.7, which is very, very high end of the healthy weight range. And this overweight or percentage portion of people. That's good. This shows just the distribution of weight by rank, and rank can often be used as a socioeconomic indicator. In this particular case, studies have shown that people with lower socioeconomic statuses have higher rates of overweight and obesity, but in our population, that doesn't necessarily hold true. And it might be because the genetic list of people are young and fit, or a number, but actually, warrant officers have the highest prevalence of overweight and obesity, followed by senior listed and senior officers. It's kind of all over the place. This is the distribution by age group. This was some of the literature, and that overweight and obesity increases with age. Starting at about the 21 through 27 age group, there was a spike observed in the prevalence of overweight and obesity. And then from there, the trend continued up until about, the 40 plus age group. 78% of them are overweight or obese. Also another thing to note, in the 40 plus age group, you can see through all the other age groups, the overweight category keeps climbing up until the 40 age group, when it appears that those people move into the obese category. So it kind of shrinks and the obese category jumps. This is just by benchmark that shows that almost half of the active duty population are overweight, and another almost 20% are obese. Again, the majority of the child population is of healthy weight. And that's good, especially in light of the statistics on childhood obesity in the U.S. The non-active adult population has almost a proportion of overweight in them. But the most alarming is the reproductive population, which has about 80% either overweight or obese. That's pretty sad. And then we have the chart by gender, which also does some of the literature in that analysis of overweight and obese. That, you can see that you have an equal proportion of obese here. Okay, so that was the demographic, and we have costs by incident and outpatient. Basically what we found were that the overweight and obese persons were hospitalized at 5 times greater healthy weight persons. They accounted for the majority of the hospitalizations and the costs, and they had $855. It cost $855 more on average per admission. That's actually between the weight groups. And this just kind of illustrates what was in the table. You can see the difference between the groups there for class. And this is the outpatient. Again, the majority of the encounters were from overweight and obese persons. On average, they had a much higher number of the healthy weight, and they cost a lot more, about $1,088 more on average encounter. That illustrates that goal. And as far as chronic diseases go, this is pretty much what we found, in the literature, that overweight and obese persons have the highest prevalence of chronic disease, and it's about 3/4 of them had at least one chronic disease. Prevalence rate was about 700 per 1,000 of overweight obese persons that had chronic disease. And when you look, that first column there shows the number of chronic disease diagnoses across all encounters, and you can see the overweight obese persons had last section was just evaluated, the leading diseases among each weight group, and top 5 for overweight and obese versus multi-weight. These are across all diets. But this table, kind of a busy table, but you see there the last one has the rate ratio. So see kind of there how much higher the one's rates were in the overweight obese population compared to the healthy state. From that out, the overweight obese persons were almost 2 times more, or had almost 2 times more non-traumatic joint disorders and back problems. 3.8 times more central hypertension. Down at the bottom there's 4.5 times more diabetes mellitus without complications. 2.5 times more esophageal disorders, and 2.2 times circulatory disease. So that's just kind of a glimpse into our preliminary findings. We're still more to do as far as evaluating this.
Can everybody please mute their phones? Thanks.
Okay, thanks, Jenny. Let's find that out. We just have a couple more things to go over, and then we'll wrap up. Anyone have any questions on the data Jenny presented? The slides that I put on the file share, and you can look through some of the more detailed pieces later, and then we're also eventually going to publish this, so you'll have an opportunity to test our methods, test our statistical prowess, etc. Hey, the last chart's really the interesting one. I had diet, I think he thought it was funny to put it in a donut, but the over the total cost, outpatient cost for the obese overweight group twice the healthy weight group. It's really staggering. $2.6 billion out of our cost expenditure. So certainly a large and significant portion of the population. And I want to look at a couple of tools that PASA has for you. If you have a PASA account, restricted applications, you may be familiar with the requirement, because we have PHI level data to get a token assigned for a particular application. The BMI is different. It's unrestricted access. You only need to have a CAC-enabled machine, be capped in, and then be coming from a .mil domain or VPN into a .mil domain. The BMI tool's got 3 primary applications inside it: the weight category, the metric, and the action list. So why don't we just jump over into the live site. To find it, you go through from the PASO main page, go under My Apps, and you select BMI. Brings BMI main. You see that body mass widget that we talked about earlier. Watch, I'm going to you guys. Up on the feet. 5 feet, 11 inches. Probably 180 pounds. 25.9. So you're overweight. Stand of the army. All right. So a couple things to take a look at here are pretty basic applications. The weight category just cuts up all Brian's data, and so you don't have to worry about pulling some of this aggregate data down. The next one's the PBM metrics we'll look at in a minute, and then the action list itself. So if we go into the MI categories, this is a really good slick tool. It lets you cut up all the most recent January data that we have on patients, and it puts it in 4 different sort of primary things that you see here. The first one being patients with a calculated BMI. Gives you some of the sub numbers and puts out some nice charts to start with. This is all exportable as well. If you're interested in, say, just the active duty population here, and we haven't checked in a while, I guess. You can select just one of the subpopulations here is like 44,000. Right now. Some of the other ways to cut up the data, so right now we're looking at the Metcom view, so it's why it's taking so while, it's going through 1.4 million records. But the other ways you can do is you can drill down to the NCF, and it's just sort of just kind of like a recipe menu viewer here, so you can, if you select the Metcom, it'll expand it to your region. If I only want the RMC, I would select it. If I'm looking for something in it, I would click on it. If I want Kimbrough, I can either have Kimbrough as a whole or some of its child devices, and then you hit view and it's going to regenerate. The other interesting thing to look at is the 4 ways to look at the data. This shows you calculable BMI, breaks them in the weight category. But this one looks at your patients that don't have a calculable BMI. So in this case, of this population, we've got 28,000 soldiers we don't have a calculable BMI on. So for some reason, it was not collected from them in the last year. Enrolled patients with no employment in the last 12 months. We'll show this the PBAM metric here in a minute, but this is really important because they're both your best and your worst patients. They don't come into your facility, therefore they cost you nothing, but you have no ability to influence their overall health because they don't come into your facility. So these are patients who were enrolled to you, who you're paid for, but you have not come into your building. So into this category, and therefore are not going to ever really make that PBAM metric of 90%. And then the last bin kind of throws them all together, and in this case, this shows you how much we have BMI on, and again, you can break those down in many different ways. There's a lot to do and see there. The PBAM metric itself, we have a slide on this in the deck, I believe.
The population that we're not getting when it comes to active duty, the active duty population, what we're finding is that it's we're finding it in the majority of the posts where there's a lot of brigade combat teams that are deployed or they've been deployed for the last 12 months. So eventually, a lot of those numbers, those active duty population numbers are going to go down just based on redeployment cycles, et cetera, et cetera. So I just wanted to kind of throw that in there. The PBAM, the DEMIS level, you get $1 per enrollee, and that's done on a monthly basis. So if your DEMIS ID, your child DEMIS ID, per enrollee, and that's based on a bi-month basis. The overall MedCom enrollment, the total potential payment via PPS was $15.5 million. We haven't gotten an updated one from resource management yet. Budgetary reasons, et cetera, et cetera. And it's available to anybody that has a CAC from a .mil. You can see the PBAM metric, and you
ago, 2 years ago, and it was a Kickstarter, right? It was a way to get the MTS incentivized to get this data collected. Even though we're at about 85 to 90% in terms of collected on individual patients, it just really means that we're at the next step. The next step is to start to really use this data as further incentivize people. So, I know that the ideas behind what the new version question to the number of patients at a healthy weight category, or the negative side of that, number of patients you have being a detriment of the number of patients you have in the overweight or obese category. So if you need the P-band data, that's in here. That is an Excel document. I just pulled it. That's funny. That's like live demo. Yeah. I've never seen that before. Anyway.
Come up and open that door.
This is machine, right? Well, it's only 6, but it's machine.
Open it from what you say.
Alright, here you go. Machine.
Because it was,
here it is.
It's not.
Alright, we'll move on. You've seen an Excel sheet before, but it breaks down the RMCs and all the way down to the child. So it gives you the exact numbers of where you are for different groups. The last thing I wanted to show you is the BMI collected on. It's not a lot of help unless you can get to the information itself. So the action list tab here, are we going to hit PHI right away? The action list tab, as you know by the lock, is restricted, and this will give an opportunity to pull down by name who these patients are. We use an export builder to do that. Again, it's kind of like a recipe. You're going to go through and identify where you are, what it is you're interested in. You can go either by at the parent level or go down to the or whatever it may be, and then export that entire list. Because of the extreme sensitive nature of this data, as you might imagine, it's pretty well restricted. So Brian's got some procedures on the website to let people know how to get access. It's generally been limited to a few number of individuals at each parent in RMC.
Right. It's the local policy is 3 individuals per parent MTF, and then those individuals will serve as a conduit or will serve as the link to everybody else within their facility. I sent out an email in November when the applications became available to the regional ClinOps, and their responsibility was to disseminate that request for those individuals down to the parent level MTFs, and then send me a list back. Out of 140 available slots, I believe we're probably sitting at about 40%. There are some MTFs that do not have a single point of contact who can go out and download the data. Again, if you would like to request access to this, my request is that, again, that you go through your ClinOps people so that an MSA in a clinic somewhere, out of the, off the beaten path doesn't have access to it, and then everybody else in the MTF is going to go ask them for it.
Okay, thanks, Brian. I think that's all we have for you today. At this time, if there's any questions we didn't get to earlier, we want to bring them now. Let's go ahead and take some questions.
Colonel Wilson, if you scroll through the chat, there's a number of really good questions.
Okay, where should I start? How far up should I skip anyway?
Well, first, there's a question a while back if there will be new BMI codes in ICD-10.
I'm reading Mel Glenner's question, by the way. Thank you, Mel. Your office 8 yards from Colonel Goodman, so I would think he would have the answer to this quicker than I would. But yeah, I do believe that this BMI is going to go to an outcome-based approach. The initial piece came from just the general lack of BMI or even height weight data in the table, and then we incentivized that action and paid MTS, but quite honestly, not too many people got paid for it. The PBA measure became, I've recommended we change it dramatically because it's not too many people get paid for it because of that population of folks you have that don't come into the building. And that's really market driven. Like down here in San Antonio, it's a very aggressive and robust, comprehensive healthcare market that people have choice. The places where we see this happen, people actually meet the metric are actually our rural installations. Carlisle Barracks, I think, was one, and Fort Irwin, or places like that where they've got, there's very limited choice for those populations. Or you've got a high density of troops versus retirees. Those are all kind of connected. So the ICD-10 question, I'm going to assume that there's an increase.
There are ICD-10 because the BMI starts with D68.
Are there more of those?
There's no more.
Okay. So yeah, Royce was just checking if you could hear that there are codes in ICD-10. We don't know right off the top of my head whether or not there's more or less, or they're any more granular. If you look at that V code list that we put on the earlier slide, that gets pretty granular in terms of the range of BMI for a particular patient. But that's done sort of outside. Okay.
Want to go into that box? I think Sarah's had some questions in there. Okay. Can we count?
Yeah, this is a great question, Sarah, whoever asked about the external, outside of the external visit stuff. There is not to my knowledge, is there a way to capture this kind of information at a health fair or at the pharmacy or somewhere else like that?
You can if it does translate into an alter record. But then again, we're talking about MEPRS issues, and is it done in the clinic? Where is it done, et cetera? And if it translates into the alter record, we will pick it up in the CDR vitals table.
Right. But those, that outreach at a health fair in the community center around the installation is not going to be an opportunity. Not going to be an opportunity for an encounter in most cases, right? So we're not going to see that there. I think I'm going to tease out a couple questions. There's a VAS question down there. You see that from Colonel Koji?
Colonel Pure. Yep, right here. Well, it's not a question. He's basically making a statement that if the MPS or if that unit's perform the PHA in the battalion aid stations, it doesn't translate into an alter record because they don't have the documentation abilities at the battalion aid station. So if they do a PHA at the battalion aid station, the answer is if they do not have ALTA ability, then it does not get into the ALTA record.
Reading the one from Kimbrough here, Jay. Yeah, so I don't know what, so the question is, that the denominator includes patients who have not been in. Is there an expectation that we will proactively request them to visit so they can measure their height weight? I'm an informatics guy. I'm not going to make a clinical population health decision about or give you guys on whether or not you should bring your patients in. Editorially, if you're running a system for health, you should be actively having contact with your patients more than once a year would be my comment. Bringing them in just in for height weight is not going to meet the patient's going to initiate this, so it's not going to meet the standards for an encounter.
Right, and back to Colonel Cure, you had another question about if encounters are F-coded, soldiers are...
Yeah, that was the question I was...
Oh, okay, I'm sorry. No, our metrics don't take that into account. And as far as F-coded, do you mean in an F-MEPRS, or do you mean... I'm not... So... Is it possible possible to get the beneficiary names on the action list. It is possible, but I can tell you that we've been having some debate about that. The names and the Social Security numbers due to the Social Security Number Reduction Act. Also, we're trying to limit the amount of PHI that's flying over the airwaves. What I did do is I've spoken to an ad hoc specialist and that we provide in the EDIPN and then extract that out of their CHCS local box. Once we get that and it's proven, the intent is to place that ad hoc or a copy of that ad hoc or a link to it on our website so it's available to everybody that has access to the action list.
Jerry Keeney, you've asked a couple questions. I'll try to our ability to get timely updates on tables that come from the CDR and the MDR. We're completely reliant on the TMA guys to do those kinds of things. So right now, we feel like we've got a pretty timely response, although we're looking at, on the application now, it's through the month of January. I don't know if we have an idea.
Right, February has not been updated at the last time I looked 2 days ago.
But prior to that, we waited, a good 12 months until we got the October of 2012 data, and then from there we got the subsequent months there pretty quickly. Jerry, your other question, grayed out. Your other question there is on, will we break down the BMI? I can't read the end of it, but it looks like you're asking whether we're going to break the BMI down maybe into panels probably, or clinics of assignment, maybe something like that.
Into clinic and provider levels.
Clinic and provider levels.
I think that's going to depend on what the change is in the PBAM version of BMI, if and when it comes out. I think right now it really has no value to bring it down to the clinic level.
Okay. Betty Gamer, what is the rationale for the CDC's cutoff of 20 years old? Yeah, I find that odd as well, to be honest with you, especially since we've got 18-year-old soldiers who get lumped into the child and adolescent group. I do know that they updated the tables in 2011. I mean, one of the things, especially with percentiles, the issue becomes what is your base population, and it's been updated in 11, but need to get adjusted, I think, with a greater frequency. Before 2011, I don't think they had touched them in quite a while.
I've got a quick question. This is Bobby Gottkine from Brookhaven Medical Center. When you talked about not breaking it down into the clinic level, I mean, by using an access database, we have been able to break it down to the clinic level. And the reason that it has been helpful to us is that we've been able to give that action list out to the team so they see what the BMIs are, and we're also able to show them who hasn't come in and who has come in, so that they can be proactive when that patient does come in. So I don't know, as you look forward to look at bringing it down to that level, because it has been helpful to the teams.
Right, and my answer was really specific to the question where they asked if the BMI PBAM was going to be broken down.
Oh, okay.
The action list, yes. I mean, I would suggest as well that if at the MTF level, if they're extracting that data, they want to definitely go down to the clinic level, because they want to see, at what clinics are they not capturing height and weight based on the appointment location. So yes, but is there a plan for us to add it to our metric? Currently, there is no plan to add it to our metric, and that again is going to be part of the ad hoc that is being built that we're going to try to disseminate out to the MTFs. It will pull that data, those data points out and provide that to the MTF based on the data set that they pull off our website, which is the action list.
Okay, all right, thanks.
Here's that PBAM file we were having trouble opening earlier. Someone set this machine to open XLS files with Notepad for some reason. So here's what it looks like. It comes out in tabs, takes you down to the parent, gives you an idea of with and without the enrolled, the percentages, and down to the child. It would not be difficult for us to do this down to the third level member, or that would not be hard to do. I do feel like this is going to change. I guess the question is there's still a need for it if we change the. I guess that's a good point. I think we will change it.
Brian, can you share your screen so people can see that Excel spreadsheet?
How would that go away?
I did it.
Oh, sorry, the PBAM one. Okay, so here's the PBAM screen. This is how this breaks down. But on the action, that's a good point. It'd probably be worth it to break the actions with down to the next level. I think you're right, because particularly with our patient-centered medical homes, this should be a very valuable tool, I would think, on any, especially in the morning huddle. That's a good suggestion. Thank you.
There's some more questions coming in from the chat. One from Fort Stewart where they were clarifying their question about data collection. They were talking about situations where they might do like a public health fair, be at the PX, and the data is collected by an RN who comes back and enters the record into Alta. Can these opportunities be used to capture height and weight?
She putting it in a T-con or something?
She didn't.
Yeah, that's my guess is that they're walking it back into the T-con.
Or that's an AMCO question. That's something that they need to contact their members representative and ask that question, because when it comes to workload documentation, where it's documented, where the encounter takes place, that's really a member's question, and it's not for us to answer. But if it does get into the clinical record, we will see it, regardless of who signs off on it, whether it's an RN or whether it's a doc. We pull all encounters out of B members. So if it's brought back and it's put into a B member's location, then yes, we will see it.
Yeah, so it's clearly, there's clearly a gap here, right? So you've got a need from a population health perspective to have data entered on patients on a number of different things. Blood pressure would be one. Medication management checkups would be something different that you could do in one of those kind of healthcare settings or at the PX or wherever. BMI would be another. The primary mechanism to get it in there, though, however, is revolves around the encounter itself. You need to make sure you meet the encounter rules to get it in. And there's a question from Rita Powell, I think, on coding. I think Royce is going to answer.
So the question is asking about provider documentation for BMI. There is a coding clinic out there, I believe the second quarter 2010. I did it in the presentations. And basically in that coding clinic, what it stipulates is that the provider does not have to document BMI. BMI is a statistic of height and weight that can be captured by the ancillary personnel. It doesn't have to be documented by the provider. Obesity, on the other hand, does have to be documented by the provider because that is a diagnosis. If you need the coding clinic, I'll be more than happy to supply it, but I believe it's second quarter 2010, where American Health Information Management Association, American Hospital Association, CMS, all came together and put out that coding clarifications for ICD-9
Angelique Lawyer had a question about whether or not we can do BMI data for regions stratified by BenCat. That's a fantastic question. I don't know. Let's see. BMI for regions stratified by BenCat. here's your BenCats. So when you export this, you'll get all these numbers, and you'll be able to, you can do that, you can do it yourself here. You can do it via the action list. The action list is basically, it really is just an export builder. So if you're interested in just searching and you just want the, you probably want all, or actually you just with BMI and you'll want all over here. It's going to export that by patient in the category that they're in, and then you just do a little Excel magic and group them. Okay, Bobby, you can't see the PBAM data on your computer. Well, you saw that I couldn't see it for a second there, so we'd have to kind of troubleshoot what's going on. If you want to give Brian a call later, you can walk you through. The first question I would ask is whether or not you're at home and on the .mil domain. Other than that, if you get to the website, you should be able to get to the data. That's the key there. A good coding question here for you, Royce.
We're reading the question from Elizabeth Triner. So basically, just, yeah, they can capture it. And that's what, they can capture the BMI code. The read through the code is, the question is, the dietitian conducted a group nutrition education class and there was another 3 participants with an ICD-9 code. I'm not going to say whether or not the code's right, I'm not sure. But, and the CPT code is 97804. Could capture height and weight and eat and also notes. Absolutely, yes. Matter of fact, the coding clinic that I cited specifically talks about dietitians, but it goes on further to clarify that other ancillary support staff can capture that information. So dietitians absolutely can capture that information.
Well, the mechanism that will trigger, this is Major Nicole Doyle's question, and the question is a follow-up to the previous question, reference screening, etc. What mechanism will trigger the investigation of BMI indicating obesity and any requirement for clinical follow-up with health screenings or school physicals within yes. Well, I mean, when the data, the height and weight put into the Alta record, it provides the BMI. So once the BMI is provided, the provider needs to kind of take that into consideration when they do the encounter. Just like they would the blood pressure, the pulse, the temperature, the other information that's gathered in the pre-screening process. Print out that copy. Just several questions. Let me turn the link out. Sorry. No, not coded. Summer Wood, is there a brochure that you recommend that providers can give to the patients? There's a lot of very good information in the clinical practice guidelines. I believe there's also pamphlets out there that can be printed and provided to the patient during the visit. I also want to mention that the CPGs for BMI are in the process of being updated. Okay, good. Evelyn Patterson's got the link here for the CPGs. Toolkit, that's some information there as well. questions are trailing off, if I mention you still got something else, you want to just take a copy and paste it back in, and we can get to it. They were coming on the screen just for a while there, hard to keep up.
There was one question earlier, Colonel Wilson, if you know that if all soldiers are going to be issued a Fitbit or like a Nike Fuel band.
You know, no, I mean, that's definitely what the pilot's going to take a look at. I have no idea what the unit cost is on those things, and you know, whether or not they, you know, whether or not they even have any effects. But that's really what the pilot study is going to look at. Does this kind of stuff really matter? You know, at the end of the day, we can educate. You know, it's a classic lead a horse to water, right? So at the end of the day, we can educate, sort of track, and look to see what's going on. We're gonna learn a lot more about the type of activity. Around there. The one thing I thought we might learn, if you can still see my screen, is I often wonder whether or not this model, this is why I had Jenny do this and get it into a curve based off of the BMI on the x-axis, is to kind of look at, you know, so I thought we would be slightly bimodal, but it's really, you know, if you exclude the guys in the 39 plus, you can really sort of see a distribution here. Yet the overweight population is on the left edge of this. I think the bar is actually off by half a point here, but you know, the Army could say, hey, we could say, hey, the CDC is based on a broader group, and we're much younger, and we're fit, and we're muscular. For example, we have 20-year-old infantry guys below around 120 pounds on their back. And, maybe we make some adjustments based on that data that comes out of the pilot, but I think there's a lot left to be determined in that regard. There's been a number of other tools that come out with that as well. There's a lot of really easy things to do for, you know, you can just copy kind of what Weight Watchers does. They've got these, you know, calorie tracking, point tracking things, and you can apply the fitness, a calorie burning time to the same models, and it gives you some sort of day-to-day tracking, lets you know what those deltas are. So I think that's what's coming out with some of those tools. I've seen the previews. Okay, I see we're running up against the end of this brief. Sarah, did you have anything else you wanted to cover?
I'd like to remind people about a couple other opportunities. First is that I think we've had more questions during this course than we have during any of our other courses. So this was a really great dialogue, and thank you again, Colonel Wilson, for presenting on this topic. Clearly there's a lot of interest. And because there were so many questions, like on our other Aspire series courses, we will do a follow-up Q&A, and that's going to be next Thursday, again at 1 o'clock Eastern Time, with the same DCO link. So we'll answer any questions that come in during the post-course survey on that session, and we'll take any live Q&A for any questions that come up after this session. So please join us to hear for follow-on discussion.
We're going to add a couple more documents. Is the best thing to do to put it in the file share, or do you want to just mail it to you as a package?
You can put it in the file share now. I'll also post it to the Aspire SharePoint site with all of our other documents.
Okay, we're going to go ahead and add the TSU's memo, the CPG, the DoD CPD, as well as the coding clinic.
So I posted the post-course survey link. Please take a minute and fill that out. That helps us assess how we did, what we can do better, and what follow-on questions you have. And third, I posted the link to SharePoint, our SharePoint page in the chat. So that's where you can find the slides from today's presentations. Give us a couple hours, we'll get them up. And we'll also post those 4 resources that Colonel Wilson just mentioned. And that's also where you can find the recordings of these sessions and previous sessions. Finally, our next course will be on medical readiness, and that'll be the 3rd of April. So look for an invitation for that to come out probably early next week. With that, thank you all for joining us. We're really glad to have you, and we'll talk to you hopefully next Thursday. Goodbye, everyone.